Stop for a second. Think about the last time your doctor said, "We need to schedule you for a routine screening." Did you ask why? Did you question whether you actually needed it? Or did you just nod, book the appointment, and show up without a second thought? If you're like most people, you did exactly what you were told. And I'm here to tell you that blind obedience to every medical recommendation after the age of 65 might be one of the most dangerous mistakes you can make. I know that sounds radical. I know it goes against everything you've been taught about being a responsible patient. But after more than 2 decades of practicing internal medicine and working specifically with older adults, I've seen what happens when well-meaning doctors order tests that frankly should never have been done. I've watched people walk into clinics feeling perfectly fine, only to leave months later on multiple new medications, dealing with complications from procedures they never needed, and significantly worse off than when they started. My name is Dr. Adri, and today I'm going to walk you through 4 routine medical checkups that I would refuse if I were over 65. Not because I'm against modern medicine. I'm a doctor, I believe in science, I believe in evidence, but I also believe in something most doctors won't say out loud. Sometimes the best medical decision is to do absolutely nothing. Before I go any further, if you're someone who values honest, straightforward medical information that actually empowers you to make better decisions about your own health, hit that subscribe button right now and drop a comment telling me where you're watching from. I read every single comment, and I want to know who's out there paying attention to this kind of content. Because what I'm about to share could genuinely change the trajectory of your health in your later years. Now, before I dive into the specific tests, you need to understand one critical concept. Once you grasp this, every conversation you have with a doctor from this point forward will be different. It's called the cascade effect, and it's responsible for more unnecessary suffering in older adults than almost any other factor in modern medicine. Here's how the cascade works. You go in for a routine screening. The test finds something. Maybe it's a small abnormality. Maybe it's a number that's slightly outside the normal range. It doesn't matter. The point is, something shows up on the report. Now, your doctor's obligated to investigate, so they order another test. That second test reveals something else, something slightly different. Now there's a referral to a specialist. The specialist recommends a biopsy or a procedure. Just to be safe, they say. Just to rule things out. The procedure goes fine, except there's a minor complication, a small bleed, a bit of inflammation, nothing major, but it requires monitoring. The monitoring requires medication. The medication causes side effects, dizziness maybe, or nausea, or confusion. And suddenly 6 months after that first routine screening, a person who walked into a doctor's office feeling completely healthy is now managing 3 new diagnoses, taking 4 new medications, and struggling to do things they used to do without thinking. I have seen this exact sequence play out more times than I can count. And it doesn't happen because doctors are incompetent or malicious. It happens because the medical system is designed to find problems. And once a problem is found, the system is built to respond. Every single time. Even when the problem wasn't really a problem at all. Let me tell you about a patient of mine. We'll call her Margaret. Margaret was 73 years old, a retired school principal, sharp as a tack, independent, active. She walked 3 miles a day. She volunteered at her church. She had no complaints, none. She came in for her annual checkup because that's what responsible people do. And her doctor, following all the standard guidelines, ordered a full panel of routine screenings. One of those tests came back abnormal. I'm not going to tell you which one yet. You'll find out soon. But that one abnormal result set off a chain reaction that lasted 9 months. 3 more tests, 2 specialist appointments, 1 minor procedure. The procedure caused a small bleed. The bleed required monitoring. The monitoring required medication. One of the medications caused dizziness. And Margaret, who had been walking 3 miles a day without issue, fell in her bathroom one night and fractured her hip. She recovered. Sort of. She was never quite as independent again. The original finding? It turned out to be completely insignificant. It was never going to hurt her. But the process of investigating it absolutely did. And the question Margaret asked me during her rehab is one I think every single person over 65 should ask their doctor before agreeing to any screening test. I'll tell you what that question is by the end of this video. All right, let's get into the first test I would refuse after 65. Full body CT scans. You've probably seen the ads. Executive health packages, preventive body imaging. The promise is simple. Get a complete scan of your entire body, head to toe. Find problems before they become serious. Catch cancer early. Know exactly what's going on inside you. It sounds like the smartest thing you could possibly do for your health, right? Wrong. Here's the problem. When you scan an entire human body at the age of 65 or older, you will find something. Guaranteed. Not because there's something seriously wrong, but because bodies accumulate changes over time. Little nodules in the lungs, tiny cysts on the liver or kidneys, minor irregularities in the spine. Most of these findings are completely harmless. They've been there for years. They're never going to cause symptoms. They're never going to grow. They're never going to kill you. But the medical system doesn't know that. So the moment those findings appear on a report, your doctor is legally and ethically obligated to investigate them. A lung nodule means follow-up CT scans every 6 months for 2 years. That's multiple doses of radiation to a body that's already less efficient at repairing DNA damage. Sometimes the nodule looks slightly different on the follow-up scan, so now there's a biopsy. Biopsies of lung tissue in older adults carry real risks: bleeding, collapsed lung, infection. A study published in JAMA Internal Medicine found that whole-body CT screening led to additional diagnostic testing in 37% of participants, and the vast majority of those findings turned out to be clinically meaningless. But the tests themselves, those caused real harm, real complications, real suffering. And here's the kicker. The radiation from a single full-body CT scan is equivalent to about 3 years of natural background radiation. At 65, your cells don't repair that damage as well as they did at 40. Repeated scans compound the risk. So before you agree to a full-body CT scan, ask yourself one question. Do I have symptoms that this scan is specifically meant to investigate? If the answer is no, think very, very carefully. Now let's talk about the second test I would avoid: routine bone density scans after the age of 80. Now I know what you're thinking. Bone density scans are important. Osteoporosis is a real risk. Fractures are dangerous. And you're absolutely right. For women in their late 50s and 60s, bone density screening is genuinely useful. Finding low bone density at that age creates an opportunity to intervene with lifestyle changes and medications that can reduce fracture risk over the next decade. But after 80, the equation changes dramatically. Here's what happens when a routine bone density scan shows osteoporosis in an 80 or 85-year-old. The standard response is to prescribe bisphosphonate medications. Drugs like alendronate or zoledronic acid. These medications do increase bone density. They make the numbers on future scans look better. But here's what the research shows. Long-term use of bisphosphonates in very elderly patients is associated with something called atypical femur fractures. These are fractures of the thigh bone that occur with minimal force, and they're incredibly difficult to repair in elderly patients. There's also a risk of osteonecrosis of the jaw, a condition where the jawbone starts to die. It's rare, but it happens, and it's devastating. Here's the bigger point. After 80, the best way to prevent hip fractures is not by treating a number on a scan. It's by preventing falls, strength training, balance exercises, home safety modifications, reviewing medications that cause dizziness. These interventions have strong evidence for reducing actual fractures. A bone density scan that leads to medication without addressing fall risk is treating the measurement instead of the real problem. If your doctor suggests a bone density scan after 80, ask this: will the result of this scan change my treatment plan beyond what a fall prevention program would already recommend? If the answer is no, you have your answer. The third test I would refuse is a carotid artery ultrasound in a patient with no symptoms. The carotid arteries are the two large blood vessels in your neck that supply blood to your brain. Over time, they can develop plaque buildup. If a piece of that plaque breaks off, it can cause a stroke. So, it makes sense to check them, right? Find the problem. Fix it before a stroke happens. Except the evidence doesn't support that logic. The procedure used to treat significant carotid narrowing is called carotid endarterectomy. It's a surgery where they open the artery and remove the plaque. And that surgery itself carries a risk of causing a stroke. Because disturbing plaque near the brain is inherently risky. In patients who have already had symptoms, a mini stroke or TIA, carotid surgery has clear benefits. But in patients with no symptoms at all, multiple large studies have found that for people over 70, the surgical risk of stroke equals or exceeds the stroke risk of doing nothing and managing the patient with medication alone. In other words, the operation to prevent a stroke can cause the exact event it was supposed to prevent. The American Heart Association guidelines are clear. Routine carotid ultrasound screening in adults without symptoms is not recommended, yet it continues to be ordered all the time. If your doctor recommends it and you have no symptoms, ask directly. If this scan finds narrowing, what's the stroke risk of surgery compared to optimizing my blood pressure and cholesterol with medication instead? You deserve both numbers. And now, the fourth test. The one I think is the most dangerous. Aggressive cardiac catheterization after a positive stress test in a patient with no symptoms. This is the cascade I see most often, and it's the one that causes the most harm. Here's how it goes. A patient over 65 with no chest pain, no shortness of breath, no symptoms of any kind, goes for a routine cardiac stress test. The test comes back abnormal. The cardiologist recommends cardiac catheterization, a procedure where a thin tube is threaded through an artery into the heart to inject dye and image the coronary arteries. Cardiac catheterization is invasive. It carries real risks: bleeding at the insertion site, kidney damage from the contrast dye, especially in older patients with reduced kidney function, and a small but real risk of stroke during the procedure. Here's the devastating part. Two landmark studies, the Courage trial and the Ischemia trial, both published in the New England Journal of Medicine, found that in patients with stable coronary artery disease and no significant symptoms, aggressive intervention through catheterization and stenting did not reduce the rate of heart attack or death compared to optimal medical therapy alone. Medication managed these patients just as well, with far less risk. The stress test has a high false positive rate in older adults, especially women. A positive result in a symptom-free patient triggers a chain of events that the research says may not be necessary and may cause harm. Before agreeing to cardiac catheterization, ask your cardiologist, do I have symptoms? And if not, what does the evidence show about outcomes for people like me who are managed with medication compared to those who go forward with the procedure? Let me bring this all together. 4 tests worth serious thought before agreeing after 65. Full-body CT scans that find incidental findings almost guaranteed to trigger cascades. Routine bone density scans after 80 that lead to medications with serious risks when fall prevention has stronger evidence. Carotid artery ultrasounds without symptoms, where surgery can carry stroke risk equal to doing nothing, and aggressive cardiac catheterization after a positive stress test with no symptoms, where medication achieves the same outcomes without procedural risk. Remember Margaret? The question she asked me was this: Doctor, if I had known to ask one question before that first test, what should it have been? I told her. The question is always the same. If this test finds something, what will we do about it? And is that worth doing at my age and in my current health? That single question forces the conversation the system isn't designed to have. Ask it every time. Your doctor will either have a good answer or they won't, and that tells you everything. Share this video with someone you love who's over 65. The most important thing you can do for their health might be giving them this one question. Subscribe for more honest medical conversations. I'm Dr. Adri. You deserve the full picture, always.